I walked into that boardroom, and a couple of my colleagues were already there for the meeting we were going to be having, my last meeting of the day, finally. And my colleague was sitting across the table, and I was standing next to the table just laughing, joking, talking, our normal banter with one another. And suddenly I felt like I was going to get sick. So I took one step towards the door. I tried to say, I feel like I'm going to be sick, but my colleague said no words came out. And within that step, I collapsed, hit the table, flopped backwards on the floor, and entered sudden cardiac arrest.
That's Heather Baker, a school administrator in Illinois who at 28 years old nearly died. And had it not been for the swift response of her concerned colleagues, Heather wouldn't be telling her story with us today.
There was this brief conversation about what is this, what's happening, obviously shock, horror, as anybody would have when you're just going about your daily work life and you don't expect somebody to just drop dead.
You see, the difference between life and death in cardiac arrest can come down to seconds, compressions, an AED, and instinct. But sometimes it all comes down to something no one in the room can control: your gender. This is In the Heart of Care. I'm your host, Dr. Ash Panchal. Today, we're talking about sudden cardiac arrest, how it happens, when to spot it, and what to do when someone near you is experiencing it.
They knew it was an emergency, but they were a little bit split in terms of what was happening. Some people said, don't touch her. We think she's having a seizure. You should leave her alone, back away.
What Heather is describing here, that early confusion and apprehension by her colleagues, is actually pretty common when a woman is experiencing cardiac arrest. Studies show that women who experience sudden cardiac arrest in public are less likely to receive bystander CPR than men. According to an article published by the Journal of the American Heart Association in 2024, the survival benefit from bystander CPR is twice as high for men as it is for women. But Heather, a school administrator at the time, was one of the lucky ones. She collapsed in a room full of people who had at least one person who recognized her symptoms for what they really were.
Bill Fowler, the superintendent, said, we just had CPR training a month ago. I recognize what she's doing as agonal breathing because my body was gasping for air, quivering a little bit. And he said, I recognize that. I'm going to start CPR. So together they started this whole chain of response, which is incredible because they didn't have a practiced plan and they hadn't talked about it before.
What's your emergency?
People were calling 911, calling emergency contacts. Bill was doing CPR. Todd France, the high school principal, was keeping my airway open. My friend Sarah, the school psychologist, ran and got the AED. She was like 8.5, 9 months pregnant, ran back with it. And they just beautifully worked together, not knowing exactly what was happening, but knowing something was wrong. And they worked together to save my life, which is really a miracle. And I'm so grateful.
Heather's colleagues didn't have a formal protocol, but what they did instinctively, calling 911, starting compressions, grabbing the AED, is exactly what we hope for in those first critical minutes. And what Heather described, agonal breathing, confusion about seizure activity, these are some of the most misunderstood signs of sudden cardiac arrest, especially in women. So let's break down what contributed to saving Heather's life that day. Step 1. Recognize sudden cardiac arrest. That recognition didn't come from luck. It came from training, which Heather found out later is far from standard in most schools.
The fact that the school staff in my district had CPR AED training is incredibly rare. And I didn't know that at the time. When we had the training in January of 2018, I just thought, wow, okay, this is what people do. And come to find later that school districts don't provide CPR AED training for everybody. And that really came from Bill, who is a Marine. So he had this passion for emergency preparedness. And Tim King, the middle school principal, is also a firefighter, EMT. And so we had these people in place in the district who valued emergency preparedness. Once again, luckily, that training not only gave them the skills to use to save my life, meaning the technical aspect of how to do compressions well and how to use an AED. That's obviously critically important. But another piece of the training that people, I think, don't really realize is so important is actually recognizing what a sudden cardiac arrest looks like. It doesn't look exactly the way that people think it would. I think in my mind, when I first learned what happened to me, I assumed you just drop dead and your eyes are closed and you're not moving and boom, you're just out. But what I've come to learn is that something called agonal breathing takes place in the first minutes or moments after you collapse and your body's gasping for air. People can be quivering, shaking, eyes can be open and fluttering or rolling back in the head. And that's what saved my life.
Step 2, take action. Call 911 and start CPR. Because recognizing the emergency is only the first hurdle, the next critical step is overcoming hesitation and jumping into action. Hands on chest, compression steady, counting every second.
Bill had seen that video a month prior and could put two and two together that, this isn't a seizure. This is something that requires CPR. And he was able to start that chain of survival. So CPR AED training is critical for everybody to practice those skills, but also to know what to look for and gain the confidence to respond when it actually happens.
Step 3, apply the defib pads and use the AED.
Compressions are critical, but if you want to save a life from sudden cardiac arrest, you have to use that AED, preferably within the first 3 to 5 minutes, in order for that person to have the best chances of survival and minimum brain damage and minimal damage to the other organs. So in my case, the fact that our school had an AED, which is a state law in Illinois, was in our favor.
The AED guides you through every step, clear and calm.
Analyzing now. Stand clear.
Helping you deliver a shock that can reset a failing heart.
They all work the same, although they look a little bit different and the prompting might sound a little bit different. They all give the same message, and all you have to do is turn it on. You have to know where it is, turn it on. You stick the pads onto the victim, and the prompting will just walk you through exactly what to do. You can't mess up because it won't let you shock somebody who doesn't need a shock. So I like to say that these devices are super sophisticated, and luckily they just keep becoming more and more sophisticated as technology advances in our modern world. But when you put that on, it's analyzing the heart rhythm and it's looking for very specific shockable rhythms. So it's only going to advise a shock and allow you to shock somebody if they need it. So truly, it's foolproof, and it's so important that we have these machines available, accessible, and that people know that it's okay to use them.
Heather's experience didn't just change her life, it sparked a mission.
The only thing that can restore the heart back to its normal rhythm, potentially, is a shock from an AED. So you can do CPR, you can give high-quality compressions, and of course that's really important because what the chest compressions do is keep the blood moving through the body, keeps oxygen going up to the brain.
She realized that being CPR certified and ready to respond isn't just important, it's essential. And she's since made it her mission to make sure others are prepared too.
My advocacy work began after my sudden cardiac arrest, and I realized that sudden cardiac arrest was not as rare as I had thought it was, and that the public thinks it is. And with that, I found that schools were very unprepared for cardiac emergencies. I had been working in schools for quite a few years at that point, and I was shocked that I had never had CPR AED training, and I was surprised to find that most states don't require CPR AED training for teachers and school staff. So that became my area of interest for advocacy, and right now I'm working really hard alongside the American Heart Association to try to pass laws requiring not only CPR AED training for school staff, but cardiac emergency response plans and drills to make sure that people actually know what to do in the case of an emergency and they can practice that response. I woke up feeling normal. I was 28 years old. I was in my first year as curriculum director. I drove to school early, about 40 minutes through winding country roads to my school. I was there for about 4 hours. And within that time, I started to feel a little drowsy, a little headachy, but it didn't stick out to me as abnormal.
For many women, the signs of a serious heart event, like sudden cardiac arrest, can show up in subtle ways.
It can be nausea, it can be neck pain, back pain, stomach pain, and a lot of things, headaches, things that women ignore, and we just suck it up and go about our day. And if we do go to doctors, right now I'm in the class of survivors for the American Heart Association for 2025. And of that group, probably half of the women went to doctors, called 911, went to the ER, and their symptoms were dismissed. They were sent home saying it's probably anxiety, it's probably PMS, it's probably not a big deal, just go home. And those women luckily survived. But that misinformation and that dismissal of females' feelings is unfortunately really common.
And that's the heart of it. Women's symptoms don't just show up differently. They are disbelieved, brushed off as stress, hormones, even in emergency rooms. Heather's story is powerful not just because she survived, but because she's raising the alarm about the fight for equal care for women. My next guest has dug into not just the science of cardiac arrest, but the critical gaps in how we respond to it, especially for women. Dr. Audrey Blewer is a researcher and professor at Duke University School of Medicine whose work focuses on resuscitation and disparities in care. She's helping uncover why women are less likely to receive life-saving interventions and what we can all do to change that. She joins me next. Hey, Audrey, thank you so much for joining me today.
Yeah, I am delighted to be here.
It's always a pleasure to have a fellow resuscitationist on. You're also an AHA contributor, so we kind of live in the same world. Before we dive into all the seriousness, Audrey, you were part of the 2025 education guideline, writing the recommendations for the world, essentially, for resuscitation. How was that experience?
I've sat in this world for about 15 years now. I think what really excites me and energizes me about the whole process is the ability to inform public policy. I have my master's in public health and a PhD in epidemiology. So aside from everything that I do regularly, I do like being able to get back to this lens of policy and guidelines because it's really at the heart and core of public health. And I feel it's like the translational aspect, right? So that's really what excited me and motivated me through this whole 2025 guidelines process, and really excited to see how we can impact next steps, excited to see the guidelines being released, and hopefully through this whole process, impact dissemination and education.
Well, the exciting part is going to be released. The sad part is we can't talk about it quite yet.
Yeah.
But that means I'll have to grab you again and we'll have to have another discussion at that point. So today, I first wanted to start talking about gender disparities and really get into the area of your work because I think it's so motivational and ground shaking for what we are doing as resuscitationists and what we're doing on the front lines. So Audrey, what was the first thing that made you aware of the gender disparities that we're seeing in cardiac arrest and resuscitation care?
Yeah, Ash. So as we mentioned, I sit a little bit more in the space of public health, and just working on my doctoral dissertation really motivated to think about how we can address inequities as it relates to receipt of bystander CPR, and had the opportunity to analyze the Resuscitation Outcomes Consortium data and saw that in public, women are less likely than men to receive bystander CPR. And this is really in the public setting. And I think that just motivated a bit of my line of inquiry that this is informing what I'm doing to this day. But a bit of what kind of pushed us in that direction was thinking that when you have a cardiac arrest in public, compared to in the home, things are different. And prior to that, a lot of work that I had done with my mentor, Dr. Abella, was training family members of cardiac patients because they are people that would potentially need to receive CPR in the home. So flipping that a little bit and thinking about the public setting, there's a lot of potential biases that comes into play when you have a cardiac arrest in public. And who's going to respond is probably potentially a stranger, somebody that's on the street and witnesses this cardiac arrest. So there's a lot more opportunity to think about how biases may come into play in the public setting. And that's a bit of what motivated us to initially look at this publication that we had published in 2018.
The topic itself is enormous. So let's unpack some of this. And I'm going to start at the big picture and then we'll zoom in for our audience a little bit more. So when we think about these gender assumptions, how do they affect women in general, how they're treated or, I guess, overlooked during these cardiac emergencies?
Ash, I think that just taking a step back, definitely important to acknowledge that I think this is something that over the years has garnered a bit more attention, but this has been something that people have been looking at over the past few decades. And what has continually been coming up when individuals have looked at it is that perhaps people are more hesitant to do CPR or use an AED on a woman, potentially in public and potentially a woman that they do not know, because of some preconceived notions about either their anatomy, their physical appearance. Some of the top things that come up is individuals being potentially afraid of hurting a woman. There's definitely an idea that if a woman is smaller, more frail, younger, more petite, or more elderly, they may be afraid of potentially injuring the woman. And there's also assumptions about a woman having a different anatomy than a man.
Now, you've done tons of research on this topic. You've looked at this from so many different angles. You've probably spoken to frontline providers, lay people about this whole issue. When you think about the stories from the field and you think about all these individuals who are trying to help out, are there any stories that stick with you about how a woman's symptoms were dismissed or forgotten or just ignored?
I think more generally, what comes up, as you had mentioned, I sit in the resuscitation education realm, just the basic statements by individuals that they had never even thought about the female anatomy being different than the male. This is, again, coming from perspectives of frontline providers in addition to lay people, just acknowledging the fact that there's going to be breast, the chest is going to be different than the male anatomy. That comes up. And then getting back at what you're saying about 911 and the role of the telecommunicator, and when somebody is calling 911, thinking about how things may be different if it is a female patient versus a male patient, and talking to some telecommunicators about that as well, I think has been some really important work that we're diving into.
You're listening to In the Heart of Care, a podcast about leadership in healthcare, where we explore what it really takes to build strong teams, foster resilience, and stay ready in the moments that matter the most. We're brought to you by RQI Partners, a partnership between the American Heart Association and Laerdale Medical. In the UK, St. John Ambulance launched a campaign after they found that people were hesitant to give women CPR, often out of fear of touching their chest.
I was outraged to discover that 1 in 3 people don't want to give CPR to people with breasts. I think it goes to show that there's a lot more work to be done in the world in making sure that females are just as looked after as males. We want to save as many lives as possible.
To change that, they introduced the CPR bra with the message, "It's okay to save my life," printed right on the front, aimed at reminding people that quick action saves lives, no matter what the gender is. And with that in mind, let's talk a little bit about this bystander CPR, because for me, that's where the biases really kind of come into fruition. Do you think the location itself with gender is a significant contributor to a barrier?
This has been something that we've seen in the US and in international countries as well. When thinking a bit about the environment itself, that's a really interesting question that I myself have been kind of grappling with more generally in recent work, thinking a little bit about being female and needing to call 911 in a location that's in public, but potentially a little less safe environment as perhaps another location, then I think that may play into it as well. But this is a line of inquiry that we're exploring but have not published data in. But speaking to your particular question, I think it is definitely established that the public location is where we see this difference being more pronounced. But we're less sure about the community, the neighborhood, the environment, safety concerns, and other issues like that. We were doing some work in Southeast Asia, and we know that this is an international problem. So we're generally thinking about how we can address these issues and communicate well to the public, I think is key.
Now, to extend on this concept, when we think now that we truly have bystander CPR disparities, probably driven by gender, when you think about the survival outcome, do you think that is the bigger driver, and will that explain the differences?
To answer that question, from the data that's been published, it's really mixed. And what's really interesting is that even with work that we're having the opportunity to look at internationally, we see real differences depending on the cohort. And I think that some of that may be driven by, we know that this is out-of-hospital cardiac arrest it starts in the pre-hospital setting, and we know EMS systems are different. And then when you take the patient and transport them to the hospital, we know that there's different hospital systems and care and different protocols and different things that occur in the hospital that affect survival. So that in and of itself has made survival difficult to really look at. But I think, just speaking to your question, Ash, what's coming up on the top of my head is this work that we're doing looking at differences in North Carolina and the US and Singapore, and the impact of sex or gender on survival differs in the two countries. But bystander CPR is definitely lower for women in public in both settings. I also want to acknowledge that this isn't just a bystander CPR thing, that there are definitely striking differences as it relates to AED application and defibrillation. And I think there is a lot of opportunity to think about this as we think about how we improve AED application in general. I think there's a lot of opportunity from a public health perspective thinking about that, but then thinking about how we can address the training, address the education, address the awareness, and let people feel comfortable with using an AED on a female, I think is something that we all need to do more to think about as a resuscitation community, but also as it relates to just basic training that's going out there. There's a lot to move the needle in terms of thinking about defibrillation, but I think that it's important to insert this aspect of gender differences and gender disparities in that conversation as well.
Throughout our conversation, we've focused on two main gender groups, right? Women and men, and we're comparing the two. And that's simply where the research is right now. That's just where we are. But in society, especially today, we know that gender is complex and gender norms have changed since we probably started researching gender 20, 30, 40 odd years ago, right? So in your view, how has some of this research evolved to reflect all genders, or are we still in the infancy?
I think I will just acknowledge that over the years, as my sitting in this space has evolved, I think just us in the resuscitation community have come to serious questions about, with these out-of-hospital cardiac arrest data sets, are we measuring gender or are we measuring sex? And I think even as sitting in this space, we've come to realize that in a lot of these out-of-hospital cardiac arrest data sets, the variable that we are measuring is sex, and then acknowledging that gender is different and that we need to be collecting that as well. But taking a step back, I think that there's a lot of ebbs and flows and changes in that conversation. And then when you step into the international community as well, there's different conversations. I feel like there has been more conversation around needing to measure gender as it is, what the individual identifies as, and not their biological sex at birth. I think it's partially based off of where we are with the research, the available data, and thinking about how we collect that type of data. But that being said, I think we all think that that's important and something that we need to think about a little bit more, but acknowledging that it's a space that's evolving, hopefully something that we'll be able to look at a bit more in the future.
It's just how people interface. It really challenges, like for me as a dispatch person, it really challenges this one-size-fits-all approach. I guess that brings us to the last concept, right? So the last concept would be, we understand these problems, we understand these challenges. What steps can we now take to ensure that everyone feels willing, confident, empowered to perform CPR, no matter what the victim is?
An aspect that we haven't touched upon is recognizing that these differences as it relates to receipt of bystander CPR, we know there are differences in survival by age of females. And this gets back to some of the clinical aspects of it and things that we need to understand a bit more in terms of how does this aspect of bystander CPR, defibrillation, we haven't touched upon it too much, but there have been a multitude of studies that I've worked on that have shown that receipt of bystander defibrillation and just AED application, including first responders, not just looking at bystanders, is less in females compared to males in public. I think it just speaks to our need to understand a bit more of how all of these links in the chain of survival come together, the impact of all of these different links, and really as public health and health services person, thinking about which of these areas we can target and which of them are more modifiable to improve bystander CPR, defibrillation, and survival. I think that's ultimately key.
Wow, Audrey, thank you for such an amazing conversation. I really appreciate it.
Yeah, thanks, Ash. This has been fantastic.
The gaps in care between genders when it comes to cardiac health aren't just medical. They're cultural, they're systemic, and they're costing lives. Heather's story and Dr. Blewer's research really makes it clear. When women are believed and their symptoms are taken seriously and care is truly equitable, survival goes up. Thank you for joining me on In the Heart of Care. In the Heart of Care is brought to you by RQI Partners. Our producer is Ebian Abdir. Our sound engineer is Luke Badio. Our project lead is Miria St. Obet. Additional production support is provided by Jar Audio. This episode is part of our mini-series, Heartbeats Ignored, to explore more about the human and clinical impact of overlooked cardiac care events. Visit rqipartners.com/podcast. I'm Dr. Ash Panchal. Until next time.